Hello, good evening, guys. Good evening. How are you all doing? Might be exhausted, right? After the exam and now all the analysis, everything. Right. Okay, guys. So before starting the analysis, I would just like to ask, I'm not asking about the total paper. I got the review of total paper. How was it and all? I'd be asking like, how was your anesthesia part of questions? Was it solvable or were it difficult? Please write in the chat box. Did the LRR session help you guys? Solvable. Okay. So anyways, guys. Okay, chalo. Start करेंगे. Without wasting any time, we'll start with the first question. Right. The first question was, the waveform shown in the image represents which of the following physiological parameters? Again, guys, for this, I'll just go to the LRR slide where I taught you about this. This waveform is of what? The waveform is of what? This is a capnography. Capnography usually depicts what? It depicts the exhaled carbon dioxide. Capnography or EtCO2, right? The normal EtCO2 value was between, the normal EtCO2 value is between 35 to 45 mm of Hg. Is between 35 to 45 mm of Hg. Okay? We have discussed different type of EtCO2s and all. I won't be going into the details. Just we'll be discussing the answers. Okay? Now, next, guys. During general anesthesia, which nerve is commonly monitored using a nerve stimulator to assess neuromuscular blockade? Now, again, guys, again, in the topic of neuromuscular blockade, in the LRR, I showed you one thing, the guys. In monitoring, neuromuscular monitoring plays an important role. And in neuromuscular monitoring, there are different monitors used. Train of force stimulus is one of the monitor, okay, in which the nerve that we commonly use is what, guys? It is the ulnar nerve. And what is the muscle that is being commonly used? It is the adductor pollicis muscle. Adductor pollicis muscle. We give some twitch. During general anesthesia, which is the nerve commonly monitored using a nerve stimulator, it is always the ulnar nerve. Right. Next. Yeah. Someone wrote attempt of intubation attempt is failed. Again, if you give too much dose of succinylcholine, patient might land up into phase 2 block. Okay. Failed intubation attempt and all. What is the next step? If your intubation attempt has failed, you have to go for the next best thing, that is to ventilate the patient. How would you ventilate? Either by inserting a supraglottic airway device, which is an LMA, or either by a bag mask ventilation with 2% technique. But if bag mask ventilation also fails, then you declare it as a cannot intubate, cannot ventilate scenario. We'll discuss that in the next question, okay? As you guys ask over here, I told you, okay? Is it stuck? Right. Right. Guys, are you able to hear? I think it's not stuck. Okay. Right. A patient under anesthesia. Now, coming to your question. A patient under anesthesia is found to be in a cannot intubate, cannot ventilate scenario. What is the next best step in management? Come on, guys. Cannot intubate, cannot ventilate. Guys, was this question exactly asked like this? Right? There might be wordings might be different, but most of the students, they told this was the question. So if at all you see a cannot intubate, cannot ventilate scenario, what you will do? Just look over here. Look over here. Again, I'll go back to the LRR. As I told you guys, in difficult airway society guidelines, the first thing is what? Always give your best attempt for the intubation. Take laryngoscopy, keep a video laryngoscope, take your laryngoscopy, give a good position, do a good laryngoscopy and try your best to intubate. If the first attempt fails, then your aim should be, I should ventilate the patient. Now for ventilating the patient, the second thing is what? You ventilate either by LMA Or if LMA fails, if you're not able to ventilate by LMA, you go for a 2% technique. One person will be holding the mask, other person will be bagging. Okay? But if plan C also fails, then you have to go for what? Then you have to, basically plan C, if it fails, you have to declare it as CICV. Cannot intubate, cannot ventilate scenario. You have to go for scalpel cricothyrotomy. Okay. Yes, but the option was direct cricothyrotomy. Yes, cricothyrotomy, anything, scalpel or needle, cricothyrotomy. If it was given, that is the option. That is the answer. So they asked with maxillofacial trauma and patient cannot be ventilated or intubated. What's the next step? Again, you go for cricothyrotomy. That is the next best option. Is it clear? Right. Now, guys, next question. Next question would be this, or next question would be I'll again discuss. A patient was intubated and was on mechanical ventilator for weeks. He develops inspiratory stridor. Which narrowing would have been the cause for this? Either they have asked this question, or either they have asked what is the narrowest portion of the adult airway. Okay. So guys, this was asked or not, I don't know, but these were the wordings of the students who told that similar to this, a question was asked. So guys, in this scenario, if a patient was on mechanical ventilator and intubated for a long time, then what will happen? Long time intubation. Okay, this was the question. Not a patient, it was adult, right? Adult patient only. Okay, right? We'll assume it as an adult patient. Right. So what is happening, guys? Remember, if the question was, what is the narrowest portion of the adult airway? Your answer should be what? Glottic opening. That is basically asking about the anatomy. Okay? If the question was, what is the narrowest portion of child's airway? It should be subglottis. But over here, the patient is intubated for a long time. When he is intubated for a long time, what will happen? Due to intubation, remember, once you intubated, there will be this cuff. Due to the pressure of the cuff, there might be necrosis. Okay, sometimes there might be necrosis, sometimes there might be inflammation, sometimes sometimes due to this tube there might be trauma to the inner part of the trachea. Due to that, what happens, guys? The patient develops subglottic narrowing that leads to inspiratory stridor. Okay, so the answer over here is what, guys? Subglottic narrowing, if this was the question. If the question was what is the narrowest part of adult airway, then the answer is different. No, supraglottic narrowing is not the answer. Subglottic narrowing. Supraglottic, no. We have intubated the patient. Tube is inside the glottis. Remember, endotracheal tube is an infraglottic device, not a supraglottic. Okay. Now, a patient under surgery develops malignant hyperthermia. He is RYR1 positive. It involves which channel? Again, guys, the wordings cannot be the exact, just the question was asked in this manner. So when they asked about malignant hyperthermia, I have stated again, sir, anatomy, sir told glottic. Glottic, supraglottic. No. Remember, if patient was intubated, it is always the subglottic stenosis. Supraglottic means what? Supraglottis is above the glottis in the larynx. Usually it is LMAs are the supraglottic devices. Okay. So anyways, guys, look over here, malignant hyperthermia. In malignant hyperthermia, again, going back to the LRR slide, I told you malignant hyperthermia is what, guys? A person who is RYR1 gene positive, yani he's having this mutation. In those persons, if we give some triggers, what triggers? There are many triggers in anesthesia, guys, such as local anesthetic, such as lignocaine is a trigger for malignant hyperthermia. If person is RYR1 positive, I give lignocaine, malignant hyperthermia can be triggered. Scoline is a trigger for malignant hyperthermia. So remember, if I give scoline to RYR1 positive patient, what will happen? It will stimulate the abnormal ryanodine receptors that leads to release of the calcium, and that calcium release leads to a sustained contraction starting in the masseter muscle, thereby the whole body gets involved. And treatment of choice or drug of choice for malignant hyperthermia is You know it, dantrolene sodium. So, okay. So, a patient undergoes malignant hyperthermia. What happens? Which channels get involved, guys? It is the calcium channels. It is the calcium channels. Okay. There are many triggers of malignant hyperthermia. In anesthesia, many drugs can cause malignant hyperthermia. Right? Now, in the image shown below, identify the function of the marked structure of the endotracheal tube. First of all, guys, this is an endotracheal tube. Yes, but this is a tracheostomy endotracheal tube, not an oral endotracheal tube. But basically, they are asking what? They are asking about this structure which is being shown over here. What is this structure? This is what? This is the cuff. So, what is the function of the cuff? Again, going back to our LRR, I told you this is the cuff of the red rubber tube. Initially, we were having high pressure, low volume cuffs. Okay. So what is the function of this cuff, guys? Just look over here. Going back to our notes, I told you. Imagine, guys, just look over here. If I put an endotracheal tube like this, which is cuff, which is without cuff, and if I put an endotracheal tube with cuff, what will this cuff do? Cuff will prevent the dislodgement of the tube. It will make sure that the tube is in the position. It won't be coming out. Okay? It prevents the dislodgement. Apart from that, it prevents aspiration. It prevents aspiration and also leakage of gases. Okay. So you need to remember what is the function of the cuff, guys. Function of the cuff is prevention of leakage of the gases as well as aspiration. ठीक है भाई? चलो. Next. Next, coming to the controversial question. Controversial question means what? Most of you are feeling like this question was a bit tough and all. Okay. A patient is scheduled for laparoscopic surgery under general anesthesia. Some students told it was lap appendix. Some students told it is lap cholecystectomy. Okay? In a daycare setting. Which of the following factor makes him unsuitable for daycare surgery? Come on, guys. So are the options right, guys? Home is 45 minutes drive away from the hospital. Surgical procedure is expected to last over 1 year. Sorry, 1 hour. No attendant is available and ASA grade 3. First of all, guys, remember, if it is lap cholecystectomy or lap appendix, both can be done in a daycare setting. Now, some of you might be thinking, sir, lap appendix and lap chole, why would do in daycare setting? It can be done, guys. Laparoscopic means what? Minimal invasive surgery, which involves minimal amount of blood loss. If you are suspecting appendix and the patient is having appendicitis and the patient does not have any peritonitis and all, it can be done in daycare setting. But he's asking who is unsuitable for daycare surgery. Normally, we take patients for daycare surgery if their home is 1 hour away from the, yani they stay near to the hospital, we take for daycare surgery. Now you must be thinking, why near to the hospital daycare surgery? Why? Because daycare means what? Surgery on the same day, discharge on the same day. I do the surgery, send the patient at his home. Like I do the surgery, I keep in the post-op, and then I discharge the patient to his home, advising what? If at all any emergency comes, any complications like bleeding, vomiting comes, you come back. Okay? If he is staying within 1 hour of duration of drive, he can be posted for daycare surgery. So this patient is basically ideal candidate for daycare surgery. That's not our answer. Okay. Now, the surgical procedure is expected to slightly last over 1 hour. Remember, guys, for daycare surgery, we take the patients whose surgical duration is mostly 1 to 2 hours. 1 to 2 hours, slightly over 1 hour, we can take. Okay, 1 to 2 hours. Sometimes if it is more than 2 hours also, okay, we can take, right? Sir, which is more painful, propofol or ethambutol? Propofol, okay? It was asked. So there was an option with general anesthesia over 1 hour. Yes, general anesthesia over 1 hour, you can take. Right? Next. We'll discuss option C later. Next is option D. Now option D, guys, ASA grade 3. Can we take ASA grade 3 for daycare surgery? Remember, guys, ASA grade 1 and ASA grade 2 are the ideal candidates for daycare surgery. But if the patient is having ASA grade 3, what is ASA grade 3? Patient having a systemic illness which is severe. Yani कि patient is having a uncontrolled systemic illness. Can he be taken for daycare surgery? The answer is basically depending upon what surgery and also whether the patient can be optimized before surgery or not. So the answer is totally, it's not totally no. If at all a patient is there who's having uncontrolled blood pressure, okay, patient is having uncontrolled blood pressure and he is posted for anal fissure surgery. Anal fissure surgery. But before surgery, I am just controlling his blood pressure. And anal fissure surgery is a minor surgery. In that scenario, ASA grade 3 can also be taken. Ideally 1 and 2. But remember, these three options can be taken. But who's not suitable? If the patient is telling, sir, I don't have anyone available in my home to take care of me. No attender is there in the home. That means you don't take him. You tell him, Bhai Sahab, please go to the hospital, stay there in the hospital. Why? Because if at all I am taking you for daycare surgery, still it is daycare, a minor surgery, there are chances of bleeding or vomiting or nausea or such kind of things. Someone has to take care of you at the home and they should bring. If he is not, if there is no one, then please send him to the hospital. Okay. But the option was stable ASA grade 3, not ASA grade. Okay, stable ASA grade or ASA grade. Stable ASA grade 3 means, again, it is the absolute correct answer. You can easily take stable patient. Stable ASA grade 3, you can take for daycare surgery. Is this thing clear, guys? These were the 6-7 questions that was asked from anesthesia. Is it clear? No adult at home. Option C, it was in home, there was no adult. Yeah. In home, if there is no adult attendant to take care of the patient, then again, the patient you shouldn't take the patient for daycare surgery. Okay. So guys, these were the questions. If at all you are finding like the question was a bit different, what we have discussed and all, please post me on the Instagram ID. I'll just go through it. Okay. Sir, one was EV unit. What EV unit? EV unit. सर ए से 3 क्यों नहीं? भाई मैं बताया ना, ए से 3 क्यों नहीं? ठीक है, देखो भाई, ए से 3 पेशेंट को आप ले सकते हो, मैं यही बोल रहा हूं ना, ए से 3 पेशेंट को आप ले सकते हो डेकेयर सर्जरी के लिए। हर ए से 3 पेशेंट को नहीं लोगे। ए से 3 पेशेंट जिसको कोमॉर्बिडिटीज, जिसकी कोई कोमॉर्बिडिटी है और आप उसको ऑप्टिमाइज कर रहे हो सर्जरी से पहले, अनकंट्रोल डायबिटीज है उसको थोड़ा सा कंट्रोल करके ले रहे हो, लेकिन ए से ग्रेड 3 पेशेंट जो पोस्टेड होता है माइनर सर्जरी के लिए, ऐसा नहीं कि कोई मेजर सर्जरी है और आप उसे ले रहे हो। ठीक है, एनीथिंग मोर गाइस, यू कैन जस्ट पिंग मी अप ऑन इंस्टाग्राम। क्लियर है नहीं है भाई? इज इट क्लियर? अभी देखो, अभी जो होना था वो हो गया। ठीक है, आपने एग्जाम दे दिया, अभी सुकून से रहो, ज्यादा टेंशन मत लो। ठीक है, होप फॉर द बेस्ट। सर घर पे अडल्ट नहीं है तो, अरे कहाँ चले गया क्वेश्चन? ठीक है, एंड देयर वाज 2 यूनिट गिवन एक्सपोजर, ये क्या है भाई? प्रोटॉन काइनेटिक ईवी, नो आइडिया। एनेस्थीसिया रिलेटेड कुछ है तो पूछ लो भाई। ठीक है, ओके, राइट, ऑल द बेस्ट गाइस। एग्जाम्स दे दिया है आपने, अभी सुकून से रहो, टेंशन मत लो, रिजल्ट आएगा, सब अच्छा ही होगा। राइट, ओके गाइस, ओके ओके, ठीक है। अभी मिलते हैं, अभी आप लोग सब नीट पीजी के लिए भी प्रिपेयर कर रहे हो, तो आप लोग अभी मिलते हैं हम नीट सेशन के लिए। अभी आप छोड़ दो एफएमजी के लिए, आप लोग ने समझ लो कि आप लोग क्रैक कर चुके हो, यू गाइस हैव क्रैक्ड एफएमजी। ओके, अभी ये मत सोचो कि ये होगा वो होगा ऐसा होगा वैसा होगा. Right, guys. So take care. All the very best. You will have a wonderful result. Okay. Bye. Patient started on a new antihypertensive medication. Where can we do operation before stabilization? When can we do operation before stabilization? Okay, just post me by. You just post me that question on Instagram. Okay, right? चलिए भाई. अगर यही क्वेश्चन था, अगर आप जो बता रहे हो यही क्वेश्चन था, न्यू एंटी हाइपरटेंसिव मेडिकेशन बोल, तो कौन सा मेडिकेशन मेडिकेशन मेंशन है या नहीं है, थोड़ा रिकलेक्ट करके मुझे आप भेज दो. एंटी हाइपरटेंसिव मेडिकेशन पे अगर कोई पेशेंट है नॉर्मली, कोई भी, तो उसको आप पेशेंट को ऑप्टिमाइज जब करते हो तो ब्लड प्रेशर उसका रखोगे आप कितना, 140/80 है, 140/90 है, तो यू कैन टेक द पेशेंट अप फॉर सर्जरी. बट अगेन इट टोटली डिपेंड्स अपॉन व्हाट सर्जरी द पेशेंट इज पोस्टेड फॉर. If the patient is posted for FES-like surgery, functional endoscopic sinus surgery, where the surgeon requires less bleeding, then we have to optimize the blood pressure more down. Medication was not mentioned. That's why this was not mentioned. That was not mentioned. I totally understand. Please post me those questions. Whatever you are making in your mind, you just post me those question on my Instagram ID. Okay, guys? ठीक है? चलो, all the very best. Thank you.